Welcome to Put Your Heart Into It, the HVC podcast centered around educating providers and staff about common clinical scenarios so that we can better treat our patients. Podcasts on this account are meant for educational purposes only and should not be used as a substitute for medical diagnoses or advice. If you have any clinical symptoms or medical questions, please consult a licensed healthcare provider.
I'm Jacob Moak. I'm one of the CT readers for our group. All right, learning objectives for today are to highlight the significance of coronary CT, also known as CCTA, and to show why it's a good screening tool and a risk stratification tool. Describe how CCTA works and what makes it such a useful tool for heart and blood vessel analysis. Show how CT can help classify different types of plaques, including high-risk plaques, which we will dive into in this presentation. Explore how plaque analysis is featured in CCTA. Provide supporting evidence to how CT can help optimize modality of therapy, including cardiac catheterization and medical therapy. And demonstrate FFR analysis on CT, which can also enhance coronary artery findings for further procedural and medical planning. All right, so screening and risk stratification. We cannot stress how much or how enough we really value our PCP colleagues, as you guys are the front runners in identifying patients who would be at risk for coronary artery disease. Anyone and everyone in this room, including myself, Dr. Kokar, Harsh, everybody, in our blood, every minute, every hour, every second, we're all developing plaques in our arteries. To what degree does it entail us assessing the risk with calcium score, which has lower radiation, but no soft plaque identification ability, versus CCTA with higher radiation, but more detailed analysis for the plaque, versus no imaging at all with medical therapy, can only be a life-saving decision that is in your hands. This is why I think it's crucial for our primary care colleagues to share this tool with us to help our patients gauge their risk and stratify for individualized optimal medical therapy. So with that said, let's get down to the nuts and bolts of CCTA. There are three components that help us interpret the CCTA imaging once it's constructed. So CT image is constructed in black and white. So a Hounsfield unit is a numerical value set to how black or white an image is on the scale per pixel of the image. For example, if an image is pitch black, it's 0. And if an image is white, hypothetically, let's say it's 10. Dark gray maybe 2, lighter gray 4, light gray 8, and eventually white being 10 and so forth. Double oblique is a feature where in every single 3D plane, X, Y, and Z, an image can be rotated 360 degrees to be able to construct a cross-sectional area, the circular view of the artery, to be represented as a 2D figure. And finally, multiplanar reformation is a 2D depiction of the 3D coronary artery represented as an entire segment to help identify types of plaques as well as artery narrowing or blockage degree. Let's dive into each of these features with visuals to help us understand. Here is the most handsome US president that we've ever had, 15th president, Abraham Lincoln. So starting with Hounsfield unit. If we take this photo of Mr. Abraham Lincoln and digitalize it with each little square unit, we can see how each square has different shades of white and black. The dark areas, including his eyes and his hair, have low numerical values, such as 4, 6, and 10, and onwards, while the forehead and face area have higher values, such as 251, 237, and onwards. We can apply that same concept to our coronary CT. As you see, this CT of left anterior descending artery coming straight down, we can see that there's an area depicting a very large dark area right there with a yellow arrow that is causing the artery to be narrowed or stenosed on the left side of the image, while on the right side has less narrowing with very white or bright features on the artery, as you can see there. These are examples of different types of plaques, okay? So the one on the left is a soft or dark plaque, while the one on the right is a calcified or bright plaque. Basically, how dark or bright a plaque results in the Hounsfield unit determines what the composition of the plaque is. As you are identifying the type of plaque causing the narrowing on CT through the Hounsfield unit, you can also evaluate for the percentage or degree of narrowing in a clearer fashion through double oblique feature of CT. Cross-sectional area, so basically an area of the circle and how much of an area of a circle changes from big to small, is the best form to assess the degree of blockage in a coronary artery. Unfortunately, arteries don't run in a perfect straight line, and therefore each and every segment of the coronary artery will have a cross-sectional area varying in all X, Y, and Z plane. Double oblique feature enables you to move each and every axis 360 degrees to reconstruct a cross-sectional area with no limits, no matter how tortuous a vessel is in each and every segment of the artery. For example, let's look at the figure on the right showing the CT visualization of the pulmonary artery. Starting with the top left corner, you have the cross-sectional cursor on the pulmonary artery represented in blue and green line. The colored lines run in a perfectly 90-degree angle with the figure showing that you did not move the lines at all. Once that locates the pulmonary artery, you then look at the right bottom corner image appearing. And as you can see here, the green and the red lines were moved in axis, so you can align the pulmonary artery perfectly parallel to its course. With that, you come up with a perfect plane or cross-sectional area that results in the bottom left image, allowing you to measure the size of the main pulmonary artery. This is the double oblique feature. Let's see another example and apply it to coronary artery. On the bottom left, the left main artery splitting into or bifurcating into the LAD and the left circumflex, we have the blue line moved on a line parallel to the left main of the LAD. On the top right corner image, we then align the orange line to run parallel to the artery again. And with that, we have the resulting image as shown in the top left corner there, with a cross-sectional area of the ostium of the two arteries, the LAD and the circumflex. Okay, so with the Hounsfield unit characterizing the types of plaques, as we talked about, and the double oblique feature to construct cross-sectional area for each and every segment of the artery, CT can demonstrate the 3D structure of coronary artery into a 2D view of every single angle in its entirety via post-processing technique called multiplanar reformation. Basically, this is the blood vessel from its proximal to distal end with all plaques and blockages represented in entirety or as a whole rather than each different segment or part at a time. Now that we understand how to read the CCTA, let's actually translate this to pathophysiology process as well as the medical pathology or diagnosis. So plaque starts forming from macrophage foam cells accumulating in arterial wall. As you can see right there in type 2, macrophage foam cells. And then those macrophages eat up or recruits extracellular lipids, as you can see in type 3, or the second left image. Those extracellular lipids then start developing larger and larger and larger core, which then thicken and eventually scar or calcify, as you can see in the small little white streak in type 5. The start of this calcification process is then bright enough on Hounsfield unit to eventually show up as a calcium score. And the early stage or mild degree of this is represented by a score from 1 to 100. And then eventually, as the plaque develops further, score above 100 depicts that with that much calcification, there is presumably much more plaque burden to moderate to severe amounts, which can then get you into the later plaque stages, the unstable danger zone that is much higher for eventual artery rupture. And that's depicted in type 6. So bottom line, as the calcium score reaches above 100, that's basically indicating that there are soft plaques that are not detected on CT calcium score that have high-risk plaque features. And because of that reason, when calcium score goes above 100, we do recommend that you start an aspirin because per ACC/AHA guidelines and Society of Cardiac CT, it is about 15 times higher risk of having a heart attack. Let's dive more into detail of plaque development to include the actual unstable plaques. So the figure on the bottom is the one that we just discussed about. The figure on the top shows those unstable plaques that we're missing in detail. These stages include the thin cap fiber atheroma, as you can see right there, as well as the intraplaque hemorrhage. As you can see from these plaques, the orange represents the fatty tissues, while the red represents actual bleed in the arterial wall, also known as hemorrhage. These are non-calcified soft plaques. The purple represents calcium or hard plaques, as you can see right there, progression of that. As the amount of calcified plaque increases, as you can see here, there is worsening soft plaque as well. Hence why higher the calcium score, the more likely the chance of rupture is depicted here. I add this comparison figure to show you that the calcium score will help you count the purples or the hard plaques to help you assume the presence of unstable plaques. However, you will not be able to show the soft or unstable plaques in detail. Only the CCTA will. And sometimes you may even have strictly soft plaques without any calcified plaques. So first, let's look at how and why statins are helpful to treat these plaques, and then look at examples of the unstable or high-risk plaques through CT. All right, so first, statins lower the molecules that develop the plaque in the first place, the main component being LDL. Not only do the statins knock out the material required to build plaque, but also reduce inflammation markers that recruits those macrophage foam cells for further development of the plaque already on the arterial wall. And lastly, statins promote hardening or calcification of the soft plaques, which basically pushes up those plaques against the wall rather than into the vessel itself, reducing the risk of plaque rupture and causing acute heart attack. So basically, you may go from having these stable plaque stages of fibroatheroma to fibrocalcific plaque, as shown here above, or go from thin cap fibroatheroma or intraplaque hemorrhage plaque to fibrocalcific plaque through the statin therapy without going through these rupture phases here. So the unstable plaques through imaging is also known as high-risk plaques on CT. There are multiple ways to assess high-risk plaques, including CTA, MRA, intravascular ultrasound, directly looking at the heart arteries, OCT, and PET scan. Please note, however, though, the most optimal modality of non-invasive assessment of high-risk plaque, which offers best spatial resolution, anatomical outline, and characteristic of plaque, is the CT. I say this since CT outlines shows outline of the heart anatomy and the blood vessels in finer detail, including smaller vessels that can't be seen on MRI or PET, while also allowing plaque analysis in vessels to identify high-risk plaques without direct engagement of the artery itself with modalities such as IVUS or OCT. So it's a good balance of both, basically. High-risk plaque or vulnerable plaque is a dangerous type of fatty or soft buildup in artery wall that is highly prone to rupturing, causing blood clots, heart attacks, or strokes. Unlike stable calcified plaques that causes blockages, These are often low density, and though they may not cause severe blockages initially, they indicate a high risk for major future cardiovascular events. Combination of 2 or more of these fatty plaques is necessary to designate the study as high risk for CT guidelines. So let's try to see how we can identify them on CT. So spotty calcification is the first high-risk plaque feature that we'll be talking about. As you can see on the top left image, there are small speckled white spots within the dark plaque in the artery wall, as depicted in the arrow. The top right shows a zoomed-in image of the artery segment, which show that the measurement of calcium are less than 3 millimeters within the dark or soft component itself. As we talked about before, this represents the plaque burden increasing with soft fibrofatty and intraplaque hemorrhage components that appears with increasing calcification. The bottom are the images from intravascular ultrasound, direct images of the artery wall and ultrasound within the artery itself showing the same thing. So essentially, those are the IVUS pictures depicting what the CT shows. This is a case report from Journal of American College of Cardiology Imaging, which shows 2 cases of napkin ring sign, another high-risk plaque feature noted in CT. On figure A on the top left corner and figure B on the bottom left corner, they show cross-sectional areas of the artery segment at the arrow, showing a very dark area surrounding the blood vessel. And that represents a pool of arterial wall bleed or hemorrhage and a thin ring around the vessel that is very prone to rupturing, hence the term napkin ring sign. The images on the right show the complete occlusion of arteries months down the line after the coronary CT finding, basically STEMI. Please note how the degree of blockages or stenosis depicted in A or C on the left side were not severely obstructed. Those vessels, probably the first one on the top was probably around 50%, if we want to overcall it. And then the one on the bottom is probably around 20 or 30%. This really shows that, you know, it's not really just the degree of blockage that we really need to worry about. It's also the high-risk plaque features that we can only see on coronary CT, not available calcium score, that can really increase the risk of patients having a heart attack. This is another high-risk plaque feature that shows the soft plaque component of the artery wall that is larger than the artery itself. Ratio greater than 1.1 times the native artery is the definition of positive remodeling. This, again, has no calcified plaque component. So even if you were to have this, if you got a calcium score, it would basically be 0. Because of these findings, as Dr. Kakar and I discussed this morning, the new Prevent ASCVD guidelines state that if you have diabetes or other autoimmune or inflammatory conditions, even despite not having chest pain, you can consider coronary CT as the first line of assessments. All right, so low attenuation plaque is the last feature of a high-risk plaque where the soft plaque is super dark. So the Hounsfield unit's less than 30. Image shows an example of it, basically with infrared light imaging to kind of help confirm that as well. These were the 4 features that we just talked about. Again, you need 2 or more of these features to be considered high-risk plaque on the imaging. So if you ever see us report on our coronary CTs that there's evidence of high-risk plaque, you're seeing 2 out of 4 of these, or in terms of number, not the types. Okay, so I placed this slide to show that I cannot emphasize enough of how important statin is. So basically, these high-risk plaque features, as we saw in the CT, is translated into these unstable plaques, or basically the plaque progression right before the rupture. If you were to start a statin therapy at this stage, there is a way that we can reduce the risk of rupture in getting you into the fibrocalcific or the stabilized plaque. Again, this is a reason why, as Dr. K just mentioned, we don't ever repeat the calcium score once we get it and it's elevated, because once you start therapy, we do end up stabilizing the plaque, and the calcium score, quote unquote, falsely elevates. Okay, that's just showing you that the plaque is becoming more stable over time, and the soft features are converting to the calcified features. So at that point, when you're on a statin, we don't know if your calcium score is going up because of therapy or, because you're getting more plaques. As you can see here, the evidence of that is shown in the CT as well. With more statin therapy, you start getting more or increased number of the Hounsfield unit, stating that the artery is becoming more stable or brighter and calcified. I use the cement analogy a lot with my patients, in which if you have wet cement, it's easier for that to dislodge and cause a heart attack, versus when it ends up drying up and really nicely paved, then there's less chance that that can rupture or break and causing a heart attack. That's exactly what a statin is doing for you. If you have 40 to 70% blockage in your blood vessels, and it was chronically developing over time where your body compensated for it, sometimes patients just come up with chest pain, and it may not be cardiac chest pain. We don't really know if it truly is cardiac chest pain or not when it's 40 to 70% at times, because the way that people present their symptoms are not all the same. So with that, we run an analysis called FFRCT. Basically what that means is you get a stenosed vessel on the top and you divide it by the normal vessel on the bottom. If the amount or of the degree of the flow is less than 0.8, then there is a concern that this is causing, chest pain. And so this was first done with direct coronary catheterization and inducing hyperemia, meaning dilating the vessel itself in the cath lab. Patients were not very appreciative of that, especially when it comes back negative and you don't give them a stent. So they thought of ways in which you can simulate the hyperemia and calculate through what's called computational fluid dynamics. Fancy term for saying we try to estimate what would happen based on the CT findings. And with that, they showed that the correlation is about 0.8 to 0.9, so about 80-90% accurate, okay? So once the FFR analysis is run, this is the type of imaging that we get. Now, why is this also important for our interventional colleagues? Because not only does it show you how functionally severe those vessels are that may require an intervention at less than 0.8, it also shows you the entire segment of where that lesion that's causing it is. So for example, figure A, you can see how the 0.41, the significant stenosis or the blockage, is very proximal. It's around the mid portion of the LAD, right after the first diagonal. That is an area that's amenable to stents. And if the patient's having symptoms and you're on optimal medical therapy, and despite that, the quality of life is severed, that you can consider a cardiac cath with an intervention. If the interventionalist has this info prior to going in, this is really going to help us plan. Versus, let's see, figure B, as you can see on the very tail end there, right before you hit the heart muscle, there's 0.77, so that is also significant as well. However, there's such a small area of an artery right before the distal end or connection to the muscle. So would that one be really feasible to a stent? Probably not. Does patient have to go through the procedure to confirm that now? With cardiac cath? Absolutely not. So this is the benefit of having FFRCT as well. With that said, these are some case examples. Basically, if you're symptomatic, it's moderate blockage, and you've got FFR that's significant, take it to cath. All right, this is a really, really busy slide, but it's very, very, very important. So I want to make sure we can go over this. This is an example of post-processing from plaque analysis. The highlighted vessel in yellow is where the plaque analysis is taking place. So the picture on the left shows the NPR view, basically the entire segment view, and it has each respective different angles to make 360 degrees. And with that, you're able to come up with plaque composition at each and every segment of the vessel itself. And that'll help you be able to analyze how much of the soft plaque and the hard plaque you're having and what type of soft plaque you're having. And the volume is listed on the side as well with that. So keep this in mind, this FFRCT analysis, and keeping this in mind with the plaque analysis, what you get is a full summary. So whenever you guys see our reports, this may be included in terms of what we're talking about. So we try to include each and every segment of the coronary artery, as well as the degree of stenosis you're having, as well as if there's high-risk plaque features and how much volume of that you have in which segments, as well as the degree of blockage and if ischemia or FFRCT results are positive or not. This is what I use to cheat and come up with the slides. All right, thank you. Any questions?
From a primary care perspective, how would you expect us to work?
Great question. So the question is basically when you order a CT, do you automatically get the FFRCT component or is it billed separately through insurance? And when would you consider it basically? So to answer your question, no, it is not included. It is a separate analysis. And so when the degree of blockage is less than 40%, we typically don't really try to proceed with FFRCT. So it is a separate billing. We don't do it if it's not moderate. And basically, if you had other functional testing, let's say you've had a stress test, such as a nuclear stress test that was positive, or an exercise EKG stress test, and the ST depression lesions were, maybe consistent with the moderate degree or higher blockage that you're seeing on the CT, you can consider that as a functional testing rather than running it through FFRCT. So sometimes when we're having discrepancies on the stress testing with the coronary CT, we would put the two together instead of having to bill the patient separately for that. Now, the plaque analysis, you haven't asked about this, but this is also very important. So the plaque analysis component, even if it is only 1%, Medicare is now approving for it because they're enhancing or highlighting how important it is for a risk of an acute heart attack. Because we know from more than 30 years of study, it's not really the degree of blockage that you're getting. Because over time, you can develop 60, 70, 80, 90% blockage and never have an acute heart attack. It's really more of the high-risk plaques. All right, thank you. Thank
Thanks for listening. Tune in next time for another cardiology-focused episode.